be speaking because I've been told mostly they are practitioners. So I've taken only those cases which are very relevant to you in your practice also. So I've not taken high-end ICU cases except the one. So we'll be discussing what multi-drug resistant type of bugs are coming to us from the community also. So we'll be discussing that, and it is going to be a simple presentation. And I'll stop only when the rationality of those antibiotics is to be discussed, and then I'll go to the experts. Otherwise, in the flow, I'll be speaking everything. Okay. So, India is the largest consumer of antibiotics, and it is second. Second is China, and then is US. And nothing to surprise, we become the antibiotic capital of the world. And as a result, we use antimicrobial use, abuse, misuse, overuse. And we have having the highest antibiotic resistance also. And we have been named as the AMR capital of the world. So this was about a decade ago when Newsweek wrote these articles, and they were in the headlines. This is the death of antibiotics, and antibiotics is the end of miracle drugs. Now imagine the life without antibiotics. Your common infections, what used to happen in pre-vaccine era, pre-antibiotic era. People used to die of tonsillitis, cellulitis, die of simple infections. Because the reason is this used to become bacteria and they used to die. Now, if these antibiotics don't work in today's time, the scenario is going to be very similar to that. All advancements of medicine, they will come to naught. Because imagine plight of cancer people, imagine the plight of your transplant patient, everyone will be suffering because all of them get infection and recover out of that. And that's the process they go through. So imagine the life without antibiotics. And WHO in 2014 said we are soon going to enter post-antibiotic era. So these are the bugs which are ruling. This is all superbugs. We'll be discussing a few of them today. Now, to summarize the whole thing, the rational antibiotic therapies can prolong the life of the antibiotic. If we keeping it, using it left and right, then we will exhaust them because resistance will come and there will be of no use. So there's a need for sagacious, judicious, responsible use of antibiotics, and that's the reason antimicrobial stewardship is critical for the future of medicine. So straight away we'll go to first case. I'll be spending 10 minutes on each case. So there are 4 cases, 10 minutes on each case, and I'll run through those so that we discuss all these 4 cases. So the first case starts now. This is 3-year-old, 7-month-old male, high-grade fever for 3 days. This child had earache on day 1, admitted with outer sensorium and neck stiffness. These are the investigations we send routinely in any serious patient. And we did blood culture also. So I'll come to Dr. Chikara. We have now 4 experts who are, Chikara, you know, is a ID expert, well-known ID expert. Dr. Snehal is an intensivist. Dr. Amrita is also intensivist, and I'm told Dr. Amit is also intensivist. So you are having a team who deal with difficult infections, and I'll be asking them these simple questions which are there. Number 1, Dr. Chikara, what is the role of blood culture in
Meningitis is an invasive disease, particularly hematogenous in origin. So therefore, a blood culture must be a blood culture. So blood culture for all invasive diseases, especially meningitis, pneumonitis, osteomyelitis, which are mostly hematogenous in origin. So therefore, a blood culture is very mandatory because that is how you are going to pick up the etiological path and your treatment pattern becomes very easy. Yeah. Hello. Hello.
Hello.
Hello.
Yes, yes. Just keep this.
So all invasive diseases be it whatever organism, are hematogenous invariably in causation. So therefore, a blood culture or an appropriate body fluid which is surrounding that organ is always mandatory if you want to pick up the bug which is infecting and plan a treatment or a rationality in your treatment.
Okay, anyone wants to add something? No. Okay. See, what happens is practically, patient gets admitted in the middle of the night. You can straight away take the blood culture, but many a times in most of the centers, the LP is done in the morning. Because you have to give sedation, you have to see fundus, all those the routines have to be done. And that's the reason the child may not be hemodynamically stable. Again, the blood culture comes handy. And that's the reason it's very important to do blood culture. And it's going to be positive in 80 to 90% of cases. Okay, sometimes there is a delay in doing LP. Now, empirical antibiotics in such a patient who is in meningitis, Dr. Snail, what do you choose today?
Yes, so empirical antibiotics will depend upon our organism which we are expecting. So in a 3-year-old, most common is going to be H. influenzae or pneumococcus.
So this is a 3.5-year-old.
3.5 years. So one ceftriaxone we should give, and recently we have seen many instances of pneumococcal and H. influenzae being resistant to ceftriaxone. In fact, let me recollect a paper from CMC well in 2017, from 2014, where the sensitivity of ceftriaxone to pneumococcal was only, resistance was only 4%. It has now jumped to 40% in 2018. So we will empirically add a ceftriaxone and a vancomycin if meningitis is there. And as in the earlier talk, if you are looking at encephalitis, then we'll even look at acyclovir, malaria hoga to Balsingo, whatever. But if you are looking at meningitis, then ceftriaxone plus vancomycin we should give.
Okay. Anyone else? I think there is unanimity on that. I think there is unanimity on this.
High dose ceftriaxone, not half-hearted.
Yes. So ceftriaxone 100 mg per kg plus vancomycin. We have been criticizing that people used to use these two combinations 10 years ago, reading the Nelson, and we used to say there is no resistance in India as far as strep pneumonia is concerned, which is the commonest cause. And now, what has happened is, first thing is antibiotics in meningitis, there should not be any delay, because as you know, the morbidity and mortality is very high. It's a time-dependent condition like MI or stroke. Must take immediate action. And this was the CSF report, and very suggestive of meningitis. Nothing to discuss about it. And we started a ceftriaxone and vancomycin. Why this change happened, as Dr. Snail said, it's not this ceftriaxone and vancomycin. This change happened after this paper, and that is a paper done written by Dr. Varghese and Balaji. And in this study, which is a study from 2008 to 2016, what happened was the blue line is the resistance of Streptococcus pneumoniae meningeal isolates. They are resistant to the tune of 42%. And if you see resistance pattern as far as ceftriaxone is concerned or cefotaxime is concerned, it is to the tune of 28.5%. It means if I only give ceftriaxone, my failure rate is going to be to the tune of 25-30%. So the discussion in our rounds was, should I count on this one paper and change everything? So this is a study done in Vellore. Why you should be following that? Because the variation in antibiotics susceptibility varies from place to place. So why we should be following this? So we had a discussion with Dr. Balaji, who is the author of this paper, and in detailed discussion he told us he has got significant numbers of isolates from North India as well. So it's very relevant to me. Unless I have a study from North India which tells me there's hardly any resistance, only then I'll change the therapy back to ceftriaxone. Otherwise, I'm quite okay with this. And otherwise, also in your practice, you used to see a lot of meningitis. Dr. Satish is there, senior people, Dr. Chakara is there. And see, we used to see a lot of meningitis in our student days in MDs and all that. So there's really pyogenic meningitis has gone down. Even if we use in an occasional patient who comes in our practice once in 6 months, there's no harm in using this. And what we should do, because I've taken the blood culture, this will be very relevant here. ये भी block हो गया अभी. Please come. So in this study, we have. Hello? Okay. Okay. So in this blood culture was sensitive to penicillin and ceftriaxone. I go back to my experts, Dr. Amruta. Should I take this on the face value?
No, sir, this is just a qualitative report. We give MIC value, that is the minimum inhibitory concentration of an antibiotic that is required to make sure that the organism, no survival organism is seen. So, as per as the, if I'm wrong, but we follow CLSI guidelines. In the CLSI guidelines, you do an MIC of the Streptococcus pneumoniae. If the MIC is less than 0.5, then you can consider stopping vancomycin and just keeping ceftriaxone or cefotaxime, but make sure it is in the highest dose. Ceftriaxone 100 mg per kg per day, 2 divided doses, and cefotaxime 300 mg per kg per day, 2 divided doses. Any case, if you see the MIC is more than 1, or say between 0.5 to 1, that is also they say, if it is between 0.5 to 1, consider it as nearer to 1, and then please don't stop vancomycin and continue ceftriaxone and vancomycin both.
Okay, very nice. So this is not the mistake of a microbiologist. We should have given her the. I think she gave a blood culture report. We should have given her because we want to use this MIC for meningitis. Possibly she could have given the MICs for meningeal isolates. So we requested her that please give us the MICs. She gave this MICs for meningitis. It is 0.5 ceftriaxone. We continued with ceftriaxone. Stopped vancomycin, as Dr. Amruta was telling you. These are the new latest guidelines, CLSI. If for CNS, your ceftriaxone MIC is less than equal to 0.5, you can go ahead with ceftriaxone. Otherwise, you should consider continuing with vancomycin as well. So child was better, markedly improved with antibiotics, only on ceftriaxone. And this is what we got in ME panel. We are putting biofire these days, and there's this streptococcus pneumoniae positive. So it confirms it is streptococcus pneumoniae in the CSF, which was obvious as Dr. Chitkara told you. And secondly, we have confirmed this, and then we are using the blood culture MICs and to use on for meningeal isolates. Okay, we gave this 10 to 14 days. Unfortunately, Amrita, this child developed deafness. So once the child developed deafness, and it was a sensory neural deafness, we noticed on day 7 or 8, when we started speaking to the child, he was not answering. So we got worried. So I think there was a discussion again in the rounds. One of the residents asked me, "Sir, we could have prevented this deafness by using dexamethasone. What's your take on this?"
So we know pneumococcal meningitis is naughty to cause deafness in around 50 to 60% cases. But whatever papers and evidence we have so far so now, etiologically, if the organism is hid, then and then the dexamethasone is showing effect. But as far as pneumococcus and other etiology is concerned, it is not showing much of effect. So I would not have started. But yes, there is a difference of opinion. I have worked with seniors who straight away start dexamethasone irrespective of the etiology between the age of 6 months to 5 years when we don't know the etiology. But yes, for pneumococcal, it will not help.
There will be big problem giving, if you are giving vancomycin and
Yes.
giving a vancomycin and a steroid, it will be a big problem. Then the neutralize the effect of your textbook.
Then we'll have to add rifampin then because it will not allow vanco to enter
Yes,
for the exam.
if you give steroids, then what happens is the permeability of membrane, meningeal membrane decreases. As a result, then vancomycin cannot enter the CSF. So that's the big problem.
So
Okay.
I would like to just add upon this as far as ICU is concerned. So the bacteriological diagnosis would come after 48 hours. So are you going to hold the steroid first dose, which will be immediate? That question comes at any bacterial meningitis. There are higher chances, 1 out of 10 can cause permanent sensory neural deafness. So I
But
would
there's,
say
so
that
there's
one dose should
agree,
be.
but there's evidence that this hearing is definitely prevented in case of if not with streptococcus.
But give.
I just shared this. Steroid reduce hearing loss in meningitis. They do not reduce mortality. The overall marked decrease incidence of hip meningitis due to vaccination. So you are mostly left with Staphylococcus pneumoniae meningitis.
So how admission
This child had already received antibiotics before.
Outside of-
तो डेक्सा अगर साथ में दिया है या पहले दिया है, then only it is going to help, not later.
Okay. But anyway, papers are there indicating even if the steroids are given, patient develop meningitis deafness in adults, 60%. And again another paper. There's not large number of papers. Anyway, when to plan cochlear implant in these cases? That's a very difficult question. In fact, it was enlightening for me. Can anyone answer? And this is in fact the crowd, anyone up to you can answer. When to do cochlear implant? The child has learned speech. He knows the speech. He is not able to hear now.
Ideal age for a cochlear implant is before the speech development. That is about 1 year. But this is a unique case where the meningitis occurred at 3.5 years. Like he says, already the speech is developed. So, if at all what you are going to benefit is the sensory result hearing loss because speech has developed. So I think once you find that the hearing impairment is sort of permanent, anything 3 months or 6 months later, then probably one should think of a cochlear transplant. Otherwise, sometimes since it is a residual deafness which is there, if the child may also improve with some hearing aid research.
So I had a discussion with cochlear implant surgeon, who is the famous one in India, and he told me in these cases, never ever delay cochlear implant. What is the reason? In a case of deafness which is congenital, it will stay like this forever. Speech is not developing, agreed. But in case of post-meningitis, what happens? The cochlear implant has some degree, cochlear inflammation is there to some degree. And this lands up with lot of calcifications, ossification. As a result, you cannot put the cochlear implant. So he says it must be done within 2 months. And it was done, unfortunately, patient was not affording and he collected money from the office and as a result, he had an implant and this was done after 7 weeks. Before that, 4 weeks, he was given PCV13 vaccine and that's it. So we go to the second case. Dr. Anil, this is a child who's 15-year male, high grade fever, shivering and vomiting for 2 days. And on day 3, a boil appears at the angle of mouth on the left side, and then in another 24 hours, it becomes swollen, another boil appears, and then there's a cellulitis, and when we had a look, it appeared as if it was going to necrosis. And then admitted with high grade fever, the child was sick looking, vitals were stable otherwise. And what is your choice of antibiotics?
So this is a infection, cellulitis is a dangerous area of face. So I would like to say that one has to be very, very aggressive to treat this child. And again, the gram-positive cover will be my area of interest. And here I would like to choose again vancomycin because we need a killer drug, not static drug like linezolid. Nowadays, many of the colleagues do start linezolid very upfront on the beginning of such kind of infection. So my choice would be definitely vancomycin in this case, plus or minus anaerobe cover if it is needed. But however, source identification and culture would be very, very important. Local as well as blood culture I would like to send.
Okay.
And then we would like to review my antibiotics later.
Okay, well said. So our choices were amoxiclav, cefazolin, vancomycin, clindamycin. Because the child was very sick, it appeared as if the child has gone into bacteremia. And for bacteremia, I think for MRSA, the drug of choice is vancomycin. And it's the bacteremia because of MSSA, the drug of choice will be cloxacillin, if not available, cefazolin. Unfortunately, this was not available also, and we started on cefuroxime and vancomycin in this case. And we waited for the culture report. We started on cefuroxime plus vancomycin, as well said by Dr. Anil. And this is the report we received. And the report is obviously on no further discussion. It is basically MRSA. You can see the report. And after seeing the report, so it is definitely PSI coming with soft and skin tissue infection. Should we de-escalate, Dr. Anil? Because we're giving two drugs, levothyroxine as well as vancomycin.
So for de-escalation, I would like to see MIC of vancomycin again. Okay, what was that value?
And MIC of vancomycin low down in the second table is less than 0.5.
So the more than or equal to 0.2, I will say that it is not a wise idea to de-escalate vancomycin. I would like to continue with
Vancomycin. Okay. Because this is MRSA, cefoxitin screen is positive, so you continue with vancomycin. I am talking about cefuroxime.
Cefuroxime, yes, has to be stopped
It has
because
to be stopped. Because there is no MSSA, so why to give it?
absolutely in MRSA again, sir, this
Why not give only vancomycin?
Sorry.
Why we should have started upfront with vancomycin only?
Because that is not a vectorostatic drug. It is going to kill.
It's not a good drug for MSSA.
Yes.
So vancomycin is not, remember this, vancomycin is not a good drug for MSSA. So you have to give both and after culture you get it. Okay. And is MIC important? Dr. Anil was telling me he is quite happy with 0.5. Okay. And this is the net, and we de-escalated now MRSA, MICs for vancomycin. If it is less than 10, no change in therapy. But if it is more than 2, there can be high clinical failure, even if the report will come as sensitive, consider the change in therapy. Anything else anyone would like to add? You are okay with it? This statement? Dr. Klas?
Two statements. Even the moderator may not agree with me. See, 2 weeks, this is a necrotizing disease with a bloodstream infection, number one. So therefore, you have to treat effectively. And if I would have been there probably, and like you said, anaerobes also. And if in my epidemiology I find that Glinda doesn't have much resistance in my community, which is now is about 20%, probably I would have started with Glinda because it is also an infective as well as a toxinic illness. Second word about bacteriostatic and bactericidal is a very relative term. We have always been misled for last 30 years. But static, the same drug can be static or cidal in different constitutions and as well as different bugs. So that doesn't hold true in the 20th, 21st century. Number three, in any case, you will not keep the child for 2 to 3 weeks in a hospital on an IV vanco, and I am sure even he would have de-escalated to oral linezolid and sent that patient home. And to say that we could not have started linezolid at the onset, even if it was a bacteremic illness, there has been a lot of debate in the last 20 years. Vanco is gradually being weaned off because it is a very narrow therapeutic index and a toxic drug. AKI is somewhere around 30% in the therapeutic range. So we don't put down linezolid under the carpet, but yet use it only judiciously for such necrotizing lesions which are antitoxin, which are invasive, and which have associated BSI. So that is my take. My panelist and moderator may not agree with me.
So let me clarify further on this. Dr. Chikara said clindamycin. Yes, we have been using clindamycin and we have been very happy with clindamycin because it covers MSSA, it covers MRSA, it covers another bug, Streptococcus pyogenes, it covers anaerobes. Fantastic. But the problem is, in recent time, we have been seeing inducible resistance in clindamycin to the tune of 30 to 40%, not 20% as Dr. Kara said. Even 20% is very high. One. Second, whenever you have bacteremia, the drug of choice has to be vancomycin or daptomycin. Our experience of daptomycin is just when we push to the wall. Otherwise, we mostly use vancomycin. I agree with this statement of Dr. Chikara. If this drug is so toxic, it should retire. But unfortunately, there's no other person to take over vancomycin. Then only can we retire it. Okay. And then, yes, please, Dr.
Sir, I would like to add something on MIC creep. Because even if the organism is sensitive to vanco and we have started because the MIC is less than 0.5, sometimes we see that after 2 to 3 days or 72 hours, the repeat culture is not sterile, we've ruled out everything, then there is something known as MIC creep. That means the MIC of the drug has gone to the intermediate or the resistant level somewhere between. That case also you have to consider shifting the antibiotic to other drugs.
Absolutely. Okay.
And
आपने डिस्चार्ज किसने किया इस पेशेंट?
Please coming to that. Okay. Okay, then we de-escalated to vancomycin, stopped cephorexime. These are the MICs. We continue to vancomycin. The question comes before I answer further. You have to answer this. How long would you manage? 10 days, 14 days, 3 weeks.
Minimum 2 weeks.
Okay, thank you.
Maybe more, but minimum 2 weeks.
Okay.
I have a different point.
So please, sir.
Dr. Amrita said that even if there is an MIC free, I would like to think that to change the antibiotic. But true to the wall, vancomycin is only working and such a thing, right? Vancomycin given in higher doses, given in longer duration. Vancomycin has got a time-dependent as well as a dose-dependent, both. So if you give higher dose, longer duration, 4 hours, we could salvage vancomycin over there also. Area under the curve will increase.
It's both time dependent, it's both concentration dependent. So area under the curve is important in vancomycin. Okay. Now this is MRSA bacteremia. Remember, whenever there is a MSSA bacteremia or MRSA bacteremia, these patients are, this bug is very notorious to cause metastatic infections and endocarditis. If these two things don't happen, in that case, as Dr. Chitkara said, this bacteremia is to be treated for 2 weeks. And blood culture should become negative after 48 hours. It became negative in our patient. And this is a summary of MRSA drugs. Vancomycin, basically it is meant for bacteremias, CNS infections, bacterial endocarditis. Teicoplanin, I think it is more protein bound, otherwise as good. Linezolid, bacteriostatic. We'll discuss some other time, discussion between bacteriostatic and bactericidal. Clindamycin, bacteriostatic. And sulfamethoxazole, the trimethoprim, useful for SSTI. Normally we use it as a step down drug. And next is daptomycin. We have used in our practice when pushed to the wall when the patient of endocarditis is not improving. Tigecycline, don't use this even if this is a good MRSA drug, because the reason is basically it doesn't reach the blood and the lung and the urine as well. Child better after 48 hours, fever pattern improved, no metastatic foci. Echo we did it, although I put it question mark, negative, blood culture was negative, echo was also normal. And day 5 of admission, we sent the blood culture after 2 days, and day 5 we had no growth. And this is the child on day 8. GC is too good, all SSTI has cleared. Now, as Dr. Chitkara was saying, किस पे भेजा आपने? तो हमने किस पे भेजा? तो हमने उसको टीकोप्लानिन आईएम में भेजा। Okay, and we could have chosen oral clindamycin, but I think the purist in the IV chapter, they always tell to continue with glycopeptide. That's the problem. I think I agree with you. I could have used Clinda, I could have used Zetran also, but I think we want to remain on the right side of purist. Okay, and this is third case. I think we are on time. Now this is a child, 2 years, 6 months, female child. Fever for 3 days, 102, 104, and this is shivering. Poor intake, vomiting, no urinary complaint, and dehydration. Dr. Snail, I am coming to you. Yes. And this is the reports. This is the report with high polymorphic nuclear shift with CRP of around 200, urea 64, creatinine 1.1, and I think this is the child is 2.5 years. Urine full of pus, WBCs, RBCs are 3-4, and this is the first documented episode of UTI. And what happened was, what is your choice of antibiotics?
Yeah, so this is GTI.
Urine culture, blood culture, we are getting.
So here we are looking at in the community there is significant. We are looking at gram negative. I expected something. In the community there is significant, at least in Surat area where I practice, there is significant ESBL seen. So my first would be a pick between DL-BLA combination versus the meropenem. Probably meropenem is an overkill over here. I will go with DL-BLA combination, a pimtaz or a piperacin tazobactam or a cephalosporin sulbactam as my
So, in other words, you have
injector choice.
in other words, you have highlighted it depends from area to area. Okay. And what about Dr. Kara? You could have started on.
This sick child who had a lot of constitutional symptoms, I would treat with surprise.
Okay. Yes, Dr. Amruta. Because I think the pediatrician should gather view. It is not only always one drug.
Sir, EFPL, chota child, I would not go for beer dealer because I am
It's the
suspecting.
first ever infection. UK. I agree. I agree. It is very
Now,
specific.
test drive don't do this, sir.
Ceftriaxone.
Test drive don't.
Because this looks. Anil.
Yes, I do agree with single drug ceftriaxone because it is the first episode. Even USG KUB is normal. No sign of pyelonephritis.
Okay, so we started on ceftriaxone and with amicus. Now, as soon as the reports came and we found, oh, this is just a minute. It was a stat dose, and then we realized, oh, urea has come 64, creatinine 1.1 in a 2-year child. The creatinine should be 0.3 or 0.4 maximum. So we were worried. We thought this is a hit on the kidney. Most possibly this is pyelonephritis, and we immediately stopped after one dose. Because in UTI, it's a very good idea to start amikacin also because most of the bugs are covered by this in today's era. And it is a very concentration dependent antibiotic. You can give one dose and get away with it. We do antibiotics before the culture, sir. Empirical. It is recommended. It is recommended. It's recommended. We stopped it because as soon as the KFT was released.
would have been normal. What would have done?
In this case, I will decide after culture and give one drug.
Dr. Shyam, suppose if you don't know the report, that means is it so that the on day one, then I don't know, I will start the 2 antibiotics?
If it is UTI in today's era, yes, you may. No problem. There's a difference of opinion is because if you go through the UTI bugs, almost all are sensitive to amikacin even today. Even this drug is 30 years old, 35 years old. All the bugs are very sensitive to amikacin. Just go through your culture reports today.
So why not only amikacin? Why not only amikacin?
See, what happens is you cannot depend on one because you are going to de-escalate soon after the antibiotics. आप de-escalate नहीं करते sir.
So the reason is why I'm worried.
I think there's no need for discussion on this.
Since we go like that,
There's no need for discussion on this.
Dr. Baldev, let me settle this controversy. सबसे पहले तो मॉडरेटर से सवाल नहीं पूछने का. Number two, see, personally we all can see 90% of UTIs are caused by E. coli. He assumed it is ESDL, it could not be ESDL, number one. So we do treat with ceftriaxone alone, most of us, and that is the feeling what we get. And they, however, whatever reason they started, but they were intelligent enough to stop it after one dose when they got those KFTs which were bad. The question is why 2 drugs? So we will not go into this controversy, but I think single drug in a kind of a, even if I think acute pyelonephritis in a patient coming from a community, ceftriaxone would suffice unless we have our local epidemiology to
It
say.
is cystitis, it is pyelonephritis. So you don't want to take any chances because another group is saying piperacillin tazobactam with higher end antibiotics. Okay, go ahead. Okay, then there's no response to ceftriaxone. I think there's no response to ceftriaxone. High fever continued, and the culture report comes. And see this culture report. And this is the scare we are having today when I say it's death of antibiotics. Your ceftriaxone MIs are more than 64. Yes, more than 64. So if you see the report today, Dr. Baldev, next time you will give amikacin. Okay. Because I have seen many reports like this. Okay, just a minute. Because otherwise you won't complete it.
After seeing the KFT.
Okay. So this is the report. And in this report, MICs are more than 64. Then see the blood culture. Absolutely ditto report. Absolutely ditto. So this is BSI, bloodstream infection originating from urinary tract. So it is from pyelonephritis. Absolutely ditto report. So what to do? And I go to again Dr. Snail.
Yes, so there is so this is vacuum infection. This is I will continue with I know others are going to.
Ceftriaxone we are now have to stop.
I will continue with
Yes, sir.
I have to do that.
Okay. Okay. So ceftriaxone resistance is defined as MIC is more than 2 microgram per ml. So it is there. So it is a proxy for ESBL production. Choice of antibiotics on the basis of culture report. How true Dr. Snail is?
I will still continue with BLBL. Although there are people who are itching to say that this is a very sick child, this is pyelonephritis, you should go to
No.
So, yeah. So right now everybody is on the same time.
So
BLBL
aminoglycoside I cannot give. Number one, because there is a hit on the kidney. Cefepime, it is not very good against ESBL. BLI combination, yes, agreed, Dr. Snail. Carbapenem, meropenem, yes, we may. Tigecycline, no way, even if sensitivity has come, because these are all drugs which are sensitive. Tigecycline doesn't come in the urine, so no idea.
3 minutes.
We complete with this and don't go to the fourth case. Okay, tigecycline and then nitrofurantoin again doesn't enter the tissue. So amoxiclav was intermediate sensitive, and we won't take a chance with intermediate sensitive in case of pyelonephritis. I could have taken a chance with this. Everyone agrees with this?
Sir,
That's all.
if it was only urine, then I would have gone for BLBL. But if it's BSI with urine showing
We will come into that. We will
then
come
I
into
would
that.
go for
So we have been choosing piperacillin tazobactam, and we chose piperacillin tazobactam, as Dr. Snail chose upfront, and we chose after our ceftriaxone failed. So now what happened was one person raised. This is 2 years or 3 years old case, and one person raised in the round. Doctor, what about Merino trial?
So yes, the Merino trial does say that meropenem vis-a-vis a BLBLI combination, meropenem, the BLBLI mortality was significantly more. Or in fact, if I may put it more properly, as purists say, they tried to prove whether BLBLI was non-inferior to meropenem. And they showed that it was definitely not the case, it was inferior. But having said that, in the same breath, let me tell you that the patient which they selected was 6 patients, immunocompromised, who has received an antibiotic in the past 3 months and hemodynamic compromised. This child did not have either of these 3-4 things. And therefore,
I fully agree with Snail.
Agreed.
And continue with BLI combination.
Yeah, and again, this is a, I would say that still jury is not completely out. There are two school of thought that piperacillin is considered as a carbapenem sparing drug, and on other way, in the same study, they were told that the mortality is higher, 1.9 times, which was very significant. So if you use piperacillin tazobactam, mortality high, and if you give the message in Indian population that no piperacillin tazobactam, if you use child is going to die and use carbapenem, then you will be again blending up with the Mumbai bug. So probably in the current scenario, we are not completely.
Okay,
jury
so
is out.
what my experts are telling, I am summarizing 3-4 slides. What they are telling you. First is this Merino trial was done in adults, 26 sites, 9 countries, including Australia, New Zealand, Canada, South Africa, and many other countries. Okay? Then it's supposed to be a landmark trial. Most people discuss about this. So what happened was 30-day mortality was 12.3% in PTZ group, that is piperacillin tazobactam. It was 30-day mortality in meropenem was 3.7. But the criticism is this in Merino trial, there were more sicker patients in the piperacillin tazobactam, and a lot of people have questioned that. If you have more sicker and terminal patient in piperacillin tazobactam, how you can expect better results with that, and how it is not going to be inferior. Now another thing is, they definitely believe the randomization was not proper. And what happens exactly as a student of ID? When you use phenotypic cultures, and in this phenotypic culture it comes sensitive, but what happens is it hides if there is a associated OXA or associated MC in the bug. For example, it comes sensitive. The bug is also carrying OXA. Bug is also carrying MC. So as a result, the result is given for ESBL but not for OXA. So as a result, what happens? You feel it is very sensitive. There have been post-hoc analysis also. In this, they found even if the MIC is more than 16, the drugs fail. If the MICs are 2, the drug succeeds as far as piperacillin tazobactam is concerned. And last, why what we discussed in our rounds was, see, it has been proven that E. coli bacteremia originating from UTI or biliary tract is supposed to be a low inoculum infection. It has been discussed in the post-hoc analysis also. It is not true with Klebsiella pneumoniae. UTI is a low inoculum infection. Patient condition is not critical. The child doesn't have any other comorbidity. No anatomical defect like gross VUR which could appreciate on ultrasound. So as a result, we gave piperacillin tazobactam and succeeded. And we discussed in our rounds that in this case, if we fail in 48 hours, we'll definitely go ahead with meropenem. Because we must give drugs which are carbapenem sparing. Otherwise, you will end up with the ICU having a lot of resistance against meropenem. So, should we give aminoglycosides on discharge once a day because the patient became okay after 7 days? Or piperacillin I call after 8 hourly. If a patient has to come to the hospital every 8 hourly, it's better not to discharge. While ceftazidime sulbactam may be given 12 hourly, or I use intermediate drug. We gave this high dose of amoxicillin and got away with the 2 weeks completion of the course. And I can stop here, not complete the fourth case.
Just a comment on Merino. While Merino concluded that carbapenems were better than piperacillin tazobactam as regards the 30-day mortality was concerned, yet there were certain limitations which both of them have mentioned. So now Merino 2 and Merino 3 is in progress. But I am sure by the time their results come, even piperacillin tazobactam and the way carbapenem resistance is growing, next time we meet in Ahmedabad with UTI, probably we'll be using something else like ceftazidime and avibactam rather than talking about piperacillin tazobactam.
Let us coming with this.
Yeah.
Let us coming with this. Okay, we'll stop here because I think this time we have run out of time. I wanted to complete in 40 minutes everything, but okay. Thank you.